Hello and welcome to our June CMF podcast. I'm Professor Naveed Sattar, Professor and Honorary Consultant at the School of Cardiovascular and Metabolic Health in Glasgow, United Kingdom. The CMF is a free educational resource for clinicians, and this podcast aims to update you on some of the latest publications in the field of cardiometabolic diseases and the implications for clinical practice. Today, I'm joined by my friend, Professor Subodh Verma. Subodh?
Well, hi, Naveed, and good morning, good afternoon, good evening, ladies and gentlemen. It's really my great pleasure to join all of you on this CMF educational resource. And it's always wonderful to spend a few minutes with my friend Naveed from Glasgow. And between the two of us, we'll be discussing some exciting new papers in the area of cardiometabolic medicine. I hope you'll find today's podcast useful.
Thanks, Subodh. So let's start with our first paper. It's by Tan et al., and it's a systematic review and meta-analysis aimed to assess the efficacy and safety of tirzepatide, a dual agonist for weight loss in patients who were living with overweight or obesity. Now, this is a meta-analysis of around about 7 trials of almost 6,000 patients with or without type 2 diabetes. And the really key interesting things that I think we saw there was around about almost 80% of patients achieved at least 5% weight loss. And remarkably, almost a third achieved 15% or more weight loss in the duration that these trials existed. There was also a good reduction in glycemia, up to about almost 2% in absolute terms. And I suppose the other key things that it nicely summarized the fact that overall AEs were not discordant between tirzepatide and placebo, other than gastrointestinal adverse events, which were higher than placebo, as you would anticipate, but not any real difference to semaglutide. So I think the authors correctly concluded that tirzepatide does have a huge potential as a weight loss drug in overweight and obesity. I think many of us in the cardiometabolic field are excited by its potential. And what we now need to do is seize the results in various outcome trials that this drug is being used in. Subodh, are you, like me, excited by the potential that tirzepatide could have in our patient population, many of whom are now living with obesity?
Yeah, completely. I think the new era of GLP-1 and GLP-1 GIP dual agonists, and then I think there's some triple agonists on the horizon, really, are a sea change for our patients with respect to overweight and obesity. And as you all know, and as our listeners know, obesity is really a central driver of cardiometabolic risk, and therefore formidable strategies such as tirzepatide that reduce weight and improve really metabolic parameters, and can be a welcome not only for weight reduction and reducing metabolic risk factors, but hopefully also to reduce comorbidities such as vascular disease, heart failure, and others that come along with overweight and obesity. So as you said, the data are compelling, and my congratulations to the authors. I'd like to also highlight the fact that almost 1/3 of individuals in this analyses actually achieved greater than a 15% total body weight loss, which is, again, quite dramatic and can have quite significant implications for our patients. And 3/4 actually achieved more than a 5% total body weight loss. So it seems like the efficacy is sustained across the entire trial population.
Yeah.
I'd also add, as you said, that weight loss reduction, whether it translates into cardiovascular risk reduction, is an open question. There are many trials that are currently ongoing. The SELECT trial is ongoing with semaglutide in people with ASCVD who don't have diabetes. There's the SURMOUNT and SURPASS trials that are ongoing with tirzepatide in people with and without diabetes, looking at whether weight loss reduces vascular events. And then there's also GLP-1 GIP trials in heart failure that are ongoing to evaluate whether they promote reverse remodeling or improve quality of life indices.
Yeah, absolutely. And as this class obviously expands in other areas, clearly there are other trials going on in other areas beyond cardiometabolic disease, because many of our patients are living with many other comorbidities. So let's see what the trial evidence shows. I suppose the key question, final question, Subodh, between, the cost is going to be the issue that will limit the use of these and how, we can use them and when we can use them. But I guess we just have to wait to see how the evidence evolves and people looking at cost effectiveness in a much more rigorous way than they've ever done before, because the benefits of this class are probably far greater in terms of total reach than many other drugs that are present in an armory.
Agree, 100%.
So should we move on to the second paper, Subodh? I'll let you.
Yeah, why don't we do that? So I think the second paper that Naveed and I have identified for you today is entitled Cardiac and Kidney Benefits of Empagliflozin in Heart Failure Across the Spectrum of Kidney Function. And this was an analysis from the Emperor Preserved trial. It was led by Dr. Sharma and colleagues from the Emperor Preserved Steering Committee. And as you all know, Emperor Preserved was a trial of people who had heart failure with mildly reduced or preserved ejection fractions. So these were people with HFpEF with an EF of over 40%. And these were people who were enrolled with or without diabetes and were randomized to receive empagliflozin or placebo. And the primary outcome of the trial was a composite of cardiovascular death and hospitalizations for heart failure. The first secondary outcome was total events, and the second secondary outcome was looking at renal decline. Now, importantly, Emperor Preserved enrolled people down to a GFR of 20 mils per minute. And this analysis has asked the question specifically about what the outcomes were in people with prevalent CKD versus people who did not have prevalent CKD. And the way prevalent CKD was defined was using standard criteria of either an eGFR of less than 60 mils per minute or a UACR of greater than 300 milligrams per gram. And when you look at the primary endpoints now and the key secondary endpoints as listed in the slide, you can see that there was really no heterogeneity with respect to the primary outcome of CV death or heart failure hospitalizations. As you know, empagliflozin in the overall trial was associated with a significant reduction in CV death and heart failure composite outcome. And here we see that in people with and without CKD, the relative risk reduction appears to be very similar or consistent. And that benefit or consistency is seen across the domains of, the individual components, including first hospitalization for heart failure, recurrent hospitalizations, all-cause hospitalizations. Now, mortality was not different from a cardiovascular standpoint or a CV death standpoint in the overall trial, and therefore that's not really relevant in the context of this sub-analysis per se. Now, the other face of SGLT2 inhibitors that is just as impressive is its effects on renal protection. And I think our audience is quite familiar with the fact that SGLT2 inhibitors prevent renal decline and they treat people who have established renal disease. And the question that was asked in the context of heart failure with preserved ejection fraction is whether the rate of decline in the eGFR slope was seen consistently in people with and without CKD. Now, this is a bit of a busy slide, but you can see here that the absolute difference between empagliflozin and placebo by prevalent CKD status is actually very similar. And essentially what this is telling us is that even as renal function declines, the ongoing sort of renal protection afforded by empagliflozin in the context of HFpEF appears to be consistent. So I find this to be incredibly important, Naveed, for several reasons. One is I think elegant work that you've done over the last several years has reminded us of the close relationship that the heart and the kidneys have in the context of heart failure. And this is a wonderful marriage when it works between the heart and the kidneys. But when there is kidney decline, we know that that really propels, from a pathophysiological and prognostic standpoint, the outcomes of heart failure. And therefore, understanding safety and efficacy in the context of HFpEF with prevalent CKD is incredibly important. The second point I'll mention here is that, as you can see in the slide that's in front of you, that AEs by CKD status were really no different. And people often worry that as renal function declines, maybe there's a risk of hyperkalemia, maybe there's a risk of hypotension or volume depletion. And that was just not the case here. So practitioners can be quite confident in the context of HFpEF while using these therapies with declining CKD status or EGFR, that they're entirely safe and they're efficacious in that regard. So I wonder what your key takeaways are, Naveed, from this paper, and how you think clinicians can use this.
Well, I mean, I think you've pretty much said it all, Subodh. I mean, I think these drugs do what they say on the tin. They, or the tin that's been now developed. We didn't realize it right at the beginning, but they are, they're almost, I would say, probably some of the best drugs that we have for treatment of patients living with heart failure, whether it's HFpEF or HFrEF. And they give us additional benefits of, slowing renal decline slopes. There wasn't clearly enough power to look at CKD endpoints in terms of hard outcomes, but that's because people living with heart failure, most of their outcomes are going to be heart failure related, right? So I think it's, I think people fixate too much about looking at different outcomes, but by and large, these drugs are fantastic drugs for people living with heart failure, whether it's HFpEF or HFrEF, regardless of CKD status. And I think that's what I take from this. As simple as that. And that they're safe, as you and I know, we and others have looked at many other reasons across different subgroups, and the results seem very consistent, regardless of subgroups, by and large. There doesn't, so we should be using these drugs much more often, and this very real reason, as I can see, for not using these drugs in patients with heart failure. Is that kind of broadly your take as well?
And CKD, yeah, I would agree with you 100% that, I think there still is a little bit of inertia when people develop renal decline, and for some reason clinicians and are a bit worried, with renal decline with respect to AEs. And this is one of the most well-tolerated class of medications that you can see a declining, renal function. And it is, those are the very vulnerable patients where you should definitely be using these therapies for renal protection and heart failure protection.
Absolutely. And I think the final point, they don't lower sugar very much when the renal decline is there, which is why we were worried. But actually, they have huge other benefits for reasons we still don't fully understand. But the benefits are there. The trials show it clearly. So it's wonderful. And, it's a wonderful new tool that we have in heart failure and kidney disease in our armory, which is really profound in many ways. Yeah.
So let's move on to our final paper. And again, Naveed and I are really excited about this one because it talks about racial differences in quality of life in patients with heart failure treated with SGLT2 inhibitors. And this is important for many reasons. One is, clinical trial representation must be representative of the people we're treating. And unfortunately, clinical trialists and clinical trials often have, unfortunately, not recruited enough individuals, from different racial groups. And, the representation, for example, of Black patients with heart failure is actually quite small in contemporary clinical trials. The representation of women in many clinical trials is also small. The representation of people from developing worlds is low. And as a, global responsible scientist or, community, we need to do better, and we need to understand, really what the outcomes are in different, ethnic groups and different racial groups, and ensure that the results are truly generalizable across the world. And Naveed and I actually were part of a recent paper from the Emperor program that we presented at the was it AHA last year? I think, Naveed, where we looked at the results of Emperor, the pooled analyses of Emperor in Black versus white patients. And we actually had some very interesting observations that we made there. And it's wonderful to see now that a similar kind of analyses across 3 trials, Chief HF, Define HF, and Preserved HF. These are trials of canagliflozin, dapagliflozin with reduced, and then dapagliflozin with preserved heart failure, looking at racial differences, particularly Black versus white patients with heart failure. Now, the question is not only important for the reasons that I've articulated, but also because the health status and outcomes and prognosis in people with heart failure do vary by ethnicity and racial status. And therefore, and this is multifactorial, of course, in terms of what drives this, and therefore understanding, whether therapies are effective to the similar degree in different racial groups is imperative. I would also add that in addition to differences in prognosis of heart failure, we also have learned over the last several years that there is a difference in the efficacy of different therapies in heart failure based on race. And, some therapies actually are less effective in Black patients compared to white patients. So this was a patient-level meta-analysis of 3 trials, Define HF, which was with dapagliflozin in people with heart failure, Preserved HF, which was dapagliflozin and HFpEF, and then Chief HF, which was canagliflozin in heart failure. And looking at the primary outcome of KCCQ, which is a patient-reported outcome validated with respect to the domains of physical function, symptoms, social functioning, etc., in heart failure. And of the approximately 1,000 patients that were evaluated in this analysis, a quarter were self-identified as Black. And these were when you compare the outcomes in these patients, patients who were Black with heart failure tended to be younger, tended to be more women, had more reduced ejection fraction, but had a similar prevalence of type 2 diabetes. But overall, the impact of SGLT2 inhibitors to improve KCCQ CSS, which is the clinical summary score at 12 weeks, were very consistent. 4-point improvement in white patients, 4.7 point improvement in Black patients, no heterogeneity between the 2 groups. And therefore, I think the key takeaways from this analysis, of course, small numbers, Naveed, but individual patient level data with 3 trials across the spectrum of ejection fraction, demonstrating that there appears to be a consistent improvement in quality of life metrics in Black versus white patients with SGLT2 inhibitors. So I think this is consistent with what you and I found in the Emperor program as well. We actually also looked at outcomes with empagliflozin in Black versus white patients and demonstrated the relative benefits were consistent, but actually the absolute risk reduction tended to be higher in Black versus white patients. So Naveed, your thought on the whole area of diversity in clinical trials and also what the implications of these data?
No, it's great. I think it's great that we're looking at, individual treatments effects in different, ethnicities. I think it's really important because we do know that, for example, different ethnicities get different diseases for different weighting of risk factors. So we need to really establish that the drug's working in different ethnicities to similar differing extents, and if so, tailor our treatment. So it's great to be able to see that these data fit beautifully that that the quality of life and side effects and particularly KCCQ, i.e., how patients feel, improve substantially, meaningfully in both Blacks and whites, broadly equally. I think that's great, and it gives us more motivation to put these things into guidelines so doctors do use these drugs appropriately in different ethnicities for the right reasons. So it's all great. I'm delighted to see it. Yeah. So with that, Subodh, I think I'm going to thank you, for that. I hope everyone enjoyed the discussion in the podcast and found it useful, and hopefully informed some of your clinical practice. For slide summaries and further publications, please head over to CMF at cardiometabolicforum.com. All of our resources are free to download for your own updates, teaching, journal clubs, etc. And to stay up to date with new updates, please join our mailing list and follow us on social media to find out when more slides, literature highlights, and podcasts go live. So thank you from me, Subodh.
Well, same here. It's been wonderful chatting with you, and this is a great resource. It's a free resource, and please use it, download it, spread the word, and let's work together as a community to try to overcome cardiometabolic disease for our patients.